Okay, so hello everyone, and welcome to this evening's TUGSS session, looking at the topic of acute appendicitis. We have a really exciting lineup for you. Just to remind everyone, if you could please make sure that your microphones are muted. We are recording this and we will make it available online on our YouTube channel, okay? Right, without too much further ado, it's my absolute pleasure to introduce our first speaker, Professor Jeremie Lefevre, who is a professor in digestive surgery in Saint Antoine Hospital in Paris, France. He specializes in colorectal surgery, specifically colorectal cancers, hereditary syndromes such as Lynch or polyposis, and also more complex cases, including anastomotic failure, rectovaginal fistula, or IBD. He has published more than 280 articles in peer-reviewed journals and has been invited to give more than 50 oral presentations in international meetings. He is a member of the Greco Board, General Secretary of the French Society of Society of Digestive Surgery, and he is here this evening speaking to us on the topic of ambulatory appendicectomy. So without further ado, I will hand over. Thank you.
Thank you very much for this very kind introduction, and thank you for the invitation to talk then about ambulatory appendectomy. So we all know that we all have to deal with the appendectomy all the time. In France, it's something like 83,000 cases per year. We know there's a huge debate about antibiotics, but so far, due to the controversial results of randomized control studies, the French guideline still propose not to give antibiotics as a first-line treatment, and surgery remains the standard of care. It's, of course, an option in case of contraindication to surgery, and this is explained by lots of reports. I just show one slide of the Kodak collaborative group. You have something like 20% of appendectomy during the first months, but when you look longer, at 2 years, you have near than half of the patients who need an appendectomy after an antibiotics treatment. So in France, the guidelines still propose surgery. Of course, it is now laparoscopic appendectomy. Just one slide by Shiraz Markaz confirming that with laparoscopic approach, you reduce the rate of bowel obstruction in the long-term follow-up. And so overall, you have a clear surgical treatment by laparoscopic, but still a median length of stay of 2 days, with finally a very safe procedure, a low morbidity rate in young and healthy patients. So we thought that it could be a really good opportunity to propose an ambulatory pathway, but at least in Saint Antoine, but I think in the majority of the facilities, the theater are different between the classic and the ambulatory pathway. Therefore, you need a preoperative selection for eligible patients. And that's why in 2015, we created a score, which is called the Saint Antoine score. And the idea and the paper was to look at patients who were discharged at day 1 after an appendectomy, with the idea that if a patient has been discharged at day 1, it could be a very good candidate to be operated in ambulatory surgery. So we look at 600 patients. We had a retrospective group, a prospective group to confirm the score, and we found 5 preoperative score, only objective score, BMI, white blood count, CRP, absence of radiological sign of perforation, and an appendix diameter below 1 centimeter. And with a number of points, you increase the probability to be discharged at day 1 and then to be a good candidate to be operated in ambulatory surgery. And so the management of acute appendicitis was then, before this study, the conventional treatment. You have a patient diagnosed before the night, is going to have the appendectomy, and in most of the cases is discharged the day after. And for patients with uncomplicated appendicitis, they are admitted in the ward. We give them antibiotics, then appendectomy, and discharge with finally 1 or 2 days of hospitalization. With the score, patient with 4 of 5 points, so the good candidates, had either an appendectomy for patient diagnosed between 8 a.m. and 2 p.m., and so discharged on the same day. And for patient diagnosed after 2 p.m., they were discharged home with antibiotics and then reconvened the day after to be operated in the ambulatory room and have a discharge the same day, so with no admission at all in the ward. We were very comforted about the fact to discharge patient home with antibiotics because you have a lot of publication and one meta-analysis with 152,000 patients, where if you delay the surgery between 13 and 24 hours, you don't increase the rate of complication. And the French guidelines published 3 years ago confirmed that surgery can be postponed for up to 24 hours in case, again, of uncomplicated acute appendicitis. So we start, and 2 years after the creation of the score, we publish our first series of 102 patients who had day surgery or ambulatory surgery, with a success rate of 90% of patients discharged at day 0, and a very low surgical morbidity of 7%, with 2% of clavien dindo 3 or 4 postoperative morbidity. You can see here the length of stay of 8 hours from the time of diagnosis to the time of discharge, even if patient waited at least 5 hours in the emergency room. Of course, you can see that 60 among the 102 patients were reconvened the day after, with non-significant success rate of discharge at day 0 of 92% compared to 76%. This score was confirmed by another team of Jean-Marc Régimbaud in Amiens. They look at their own patient and they externally validated our score with, again, a very stringent discrimination for patients who could be candidate for day surgery appendectomy. The other possibility was proposed by the team of Adeline Aubry in Pitié-Salpêtrière, which is another Parisian facility. The idea is to have a 24-hour emergency operating room unit, and so patients were operated on the same day after the diagnosis, but therefore you can see that 50% of those patients were discharged between 8 p.m. and 6 a.m. in the morning. You can see the time, the hour of discharge, 3, 4, 5, 6 a.m. in the morning, and as a patient, I wouldn't be happy to be discharged at 4 a.m. in the morning after a laparoscopic appendectomy, just to avoid one night in the hospital. So we believe that our management of immediate appendectomy for patient diagnosed before 2 p.m. and discharge home patient diagnosed after 2 p.m. was more convenient for the patient. And so we recently published our last publication of around 2,000 appendectomy between 2013 and 2020. We had 1,730 patients with a Saint-Antoine score available, and you can see that nowadays we have an ambulatory rate of 26%. You can see here the comparison between the two groups, the conventional management and the ambulatory management. Patients were younger, with a lower ASA score, of course, and more often they had an ultrasound to diagnose the appendectomy in the ambulatory room. Of course, you have a majority of patients with 4 or 5 points, 83%, but with time and experience, we started to operate patients with a lower Saint-Antoine score, and we are going to see that it is not a problem. You can see here that lots of patients with 4 or 5 points could have been operated in the ambulatory, but there is a problem of room and space in the ambulatory operating room. What is very interesting is that in the ambulatory room, 1/3 of the patients were transferred from another facility after the diagnosis of appendicitis made. So we didn't see the patient, and a huge majority of them were directly conveyed to the ambulatory room for the next day. When we look at the result, nowadays 70% of the patients are discharged home with no readmission at all during the night, and then patient had an appendectomy and discharged on the same day. So it is now the almost standard of care for ambulatory treatment, and less than 30% of patients has the appendectomy on the same day. Je suis en train de travailler. When we look at the post-operative course, 5% of unplanned consultation or admission in the ambulatory room, similar as the conventional group, same morbidity, and 91% of success in the appendectomy ambulatory group, which is a confirmation of the first paper. When we wanted to increase the number of patients, we look to the fact that some patients with 3 points, even 2 points, had an early discharge. And so we look again at our score. We confirm 4 of the 5 independent criteria that were that composed the score, with clearly a massive impact of a perforation sign in the radiological exam. And we tried to create a new Saint-Antoine score, giving 3 points for this item of radiological sign of perforation. We make ROC curves and slightly improve the area under the curve with the new SAT score, but we just simply look at the presence of radiological sign of perforation and find that there were a quite good area under the curve with just one sign. And so the future may be that just looking at presence of radiological sign of perforation can give a good to go for an ambulatory pathway. And it means that almost 88% of all the appendicitis that we see in Saint-Antoine could be candidate for ambulatory pathway, with a predictive, of course, success rate of 86%. So it could be a huge increase in the candidates to be operated on daycare surgery. And when you look at the what's done in France, we have a national database of all surgery performed, and in 2021, among 53,000 appendectomy for uncomplicated appendicitis, only 5.8% were performed in a daycare surgery. So a huge way to progress. So to conclude, ambulatory appendectomy is clearly a safe procedure with a success rate with the score of Saint-Antoine of more than 80%, with 5% of readmission or unplanned consultation. So we believe that it's a good score to select patients with uncomplicated appendicitis. It's now validated in more than 500 patients. Roughly half of the patients have 4 or 5 points. So those are the patients who are good candidates to be operated, with, again, the possibility to discharge patient home with antibiotics to be operated the next day in the ambulatory unit. It's a very good tool for transferred patients from another facility, as all the 5 criteria are objective items. And we believe it's a good tool, a very good tool to start an ambulatory pathway if you are not used to do it for appendicitis. There is some limitation, still the place in the operating room for emergencies. So you need clearly to have a good organization. And I show you, so far in France, it's less than 8% of ambulatory appendectomy. But the potential is huge. You can include also patients with 3 points with a very high probability to be discharged at day 0, but even in the future, to operate all the patients with non-perforated acute appendicitis, which represent finally more than 80% of the patients. Thank you very much, and I wait for your questions.
That is fantastic presentation. Thank you very much. We're actually going to take questions at the end, so please just put them in the chat and we will pose them to our panel at the end, okay? Now, I will hand over to my colleague, Mr. Wilson, who will introduce our next speaker. Thank you.
Hi, thank you, Alison. So it's my pleasure to introduce Sunil Patel as our next speaker. He is an associate professor of surgery at Queen's University, an attending surgeon at Kingston Sciences Health Centre. His subspecialty interest is in high-volume robotic colorectal surgery and includes research interests for colorectal cancer, inflammatory bowel disease, smartphone technology, and evidence-based healthcare. He's been invited and kindly accepted that invitation to discuss his most recent publication, which is titled The Delayed versus Early Laparoscopic Appendicectomy for Adult Patients with Acute Appendicitis. And that paper was awarded the Best Scientific Paper at the Canadian Surgical Forum in 2023. Over to you, Sunil.
Okay, thank you for that introduction. I would say that also another one of my research interests is trying to sleep more at night. So that's where this paper came from. So thank you for the invitation. I'll be speaking about our paper, The Delayed Trial. I don't have any conflicts of interest, and I want to acknowledge that our Department of Surgery and our local medical organization were the funders of this trial. So I think no surprise to anyone here, appendicitis is one of the most common indications for emergency abdominal surgery. Acute inflammation can have the potential to lead to perforation and sepsis, and that's generally the reason why it's been accepted that timely intervention is necessary to reduce the risk of complications from appendicitis. What is timely has been a bit up to debate. There has been guidelines that describe what's considered timely surgery for those with appendicitis, and this is one example of the guidelines, and this is from 2020. And it really, the guidelines have recommended that most patients should undergo surgery for their appendicitis within 24 hours, and that's in the case of uncomplicated appendicitis. Notably that these guidelines and others that from around the same time period are based on observational data only and didn't include any randomized control trial confirming the safety of this approach. In terms of Canadian specific data, and as a Canadian that practices within the system, I looked into this as well. So we assess the timing of surgery and the risk of complications in those with acute appendicitis in the province that I work in. And this included all patients with appendicitis over about a 7 or 8 year period. It included around 50,000 patients. And what we found is that the risks of complications for those with appendicitis really didn't become significant until after 24 hours, which really supports what previous clinical practice guidelines have suggested. And in addition, we found, and this is a bit controversial, that nighttime surgery wasn't necessarily more risky than daytime surgery for those with appendicitis. Operating at night has a number of problems. In other settings, for those with acute cholecystitis and laparoscopic cholecystectomy, so it found that 30-day complications were higher for those that had an operation at night. And this has been validated in a number of simulation studies that have looked at sleep-deprived surgeons and have looked at their performance doing simulation-type exercises. You know, as part of a disclaimer, I'm a Canadian surgeon and I work in a Canadian healthcare system that has some challenges. It is a universal publicly funded system. Essentially, all urgent and emergent care is delivered through this publicly funded system. And Canadian surgeons and physicians face a number of significant resource limitations, including long emergency department waits and access to the OR, as well as very long elective wait times. So within this setting that this trial was designed. Our system in Canada is really divided into academic and community hospitals for delivery of acute care surgery. And there are some important differences, but are relevant to the study that I'm presenting. For academic centers, there's generally 24 hours of in-house general surgery coverage, whether that's trainees or the consultants. Consultants who take call typically take call several nights of the week and may have regular elective activities the next day. They're typically, for most academic centers, have dedicated daytime acute care surgery OR time, whereas at night, this resource is often shared with other services, other surgical services. Community hospitals are a bit different in that attendings often take calls for 7 days straight and typically have their regular elective activities scheduled during the day. There may or may not be dedicated emergency general surgery time at these hospitals, but there can be flexible OR resources in that on-call attendees can schedule an appendectomy within their regular operating list or add on before or after their regular list. About 25% of appendectomies are being done at academic centers in Canada, whereas 75% are being done at community hospitals. Dedicated OR time has been a really important innovation for acute care surgery in Canada. We've really switched our time we're operating from the evening and nights to daytime. And this is a study of one of the hospitals I trained at that showed that more than half of emergency general surgery is now being done during the daytime, whereas most of it used to be done during the night or evenings prior to an implementation of dedicated OR time. And it really has demonstrated that there's been a practice change in terms of when patients are undergoing their operations in an emergent or urgent setting. So our study objectives for this study was to determine whether delaying appendectomy to next morning was non-inferior to immediate appendectomy. And really, this is to validate what has become a commonly adopted change in practice in Canada, and that most surgeons are waiting and operating on people with appendicitis the next morning, but this hasn't been necessarily universally adopted. So our methods, as described before, is that this is a non-inferiority randomized control trial. We had two arms. Our experimental arm was the delayed group, in which appendectomy was performed after 6 o'clock next morning and more than 6 hours after the decision to operate. Whereas the control arm was those that underwent surgery in the evening or nighttime and within 6 hours of the decision to operate. Our participants included adults with imaging confirmed acute appendicitis, and those that had an expected OR time between 8 p.m. and 4 a.m. if they had been randomized to the immediate group. We excluded unstable patients. We also excluded those that had evidence of abscess or phlegmon, pregnant patients, and we also excluded anyone that the surgeon felt was unsafe to wait till the morning based on their overall judgment. The settings was 2 academic centers in Ontario. Both had mature acute care surgical services that were very similar in their function. They had dedicated daytime operating room time. In terms of our primary outcome, this was a composite 30-day outcome of perioperative complications such as wound complications and abscesses and other complications, as well as emergency department visits, readmissions, prolonged length of stays, or reoperation. And this outcome is the same outcome we use for a number of our population-based retrospective cohort studies that were published prior to this study being implemented. Our sample size calculation was based on a complication risk of 14%, a non-inferiority margin of 15%, and a loss to follow-up of 5%. With those numbers, we got a sample size of 140 with 70 participants in each arm. I put this figure up just because non-inferiority trials can be quite confusing, and I'm often confused about these as well. But really what this chart is showing you is that the non-inferiority margin lies to the left of the line of no difference and can be interpreted in a couple ways. So those where the confidence interval crosses or to the left of the non-inferiority margin, these would be considered negative non-inferiority trials, meaning that if this was our finding, we could not conclude that non-inferiority was demonstrated. The other three situations where the confidence intervals all to the right of the non-inferiority margin would be considered a positive trial, and that non-inferiority could be demonstrated. So this is what we were hoping to achieve with this work. In terms of our study results, we had about 150 patients assessed for eligibility. Just under 20 were excluded, and this resulted in 59 in the delayed group and 68 in the immediate group. There was some crossover, meaning that some patients were allocated to delayed that ultimately underwent a quote-unquote immediate surgery and vice versa. Performed two analyses. The first was the intent to treat analysis based on the allocation, and then the second was a per protocol analysis based on what treatment they actually received, whether it was a delayed surgery or immediate surgery. In terms of participant characteristics, quite similar between the two groups. You'll note for the diagnostic imaging test, most of our patients undergo a CT scan. Some underwent an ultrasound, and one patient actually underwent both. In both cases, the signs of perforation on imaging were very low, 3 or 4%. The box on the right demonstrates the success of our intervention in that, our randomization, in that those that were assigned the immediate surgery, the median time to OR was about 3.5 hours, versus those that were delayed was 11 hours. And in terms of time of day, the blue is those that were assigned to immediate surgery, and the orange is delayed. Most of them, of the immediates, got done in the nighttime, which is the time we expected, with some pushback to the daytime because of more urgent cases being booked. For the delayed, most of them went after 6 a.m. the next morning. In terms of our outcome, this is our primary outcome, which is the composite of postoperative complications. Delayed versus immediate surgery, you can see the differences there. There was about a 10% risk of complications in the delayed group versus 22% in the immediate group. Notably, only one patient was lost to follow-up in that group. Our per protocol analysis demonstrated an even greater difference. 7.5% of patients in the delayed group had a complication versus 26% in the immediate, and that actually met statistical significance. Perforation at the time of OR, relatively low, between about 15 and 20% in both groups, with no significant difference. And I do put this up all the time. The number of total surgeons, much different between the groups. In terms of where our results lie on this non-inferiority figure, with our risk difference and confidence interval is displayed at the top, our trial found the results here, which shows that the intervention, i.e. the delayed surgery, was non-inferior to immediate surgery. So thus, this would be considered a positive trial. So in terms of our discussion, we found that delaying appendectomy until morning is non-inferior to immediate surgery as it relates to our composite outcome of postoperative complications. And we found that the delayed trial does support the commonly adopted practice, which is encouraged by a dedicated acute care surgical service with dedicated OR time. There are some limitations to our study. This study was closed early. We recruited about 90% of the proposed. There's a couple reasons for this. The first was a loss of reliable daytime OR. With the COVID pandemic and surgical backlog, some of the daytime OR that was meant for acute care surgery started to be taken over, at least in the short term. And then we also found that surgeons were becoming less willing to recruit patients to the trial. Recruiting a patient to the trial really meant that there was a 50-50 chance that you'd have to get up in the middle of the night to do the surgery, and there was more reluctance to do that as the trial went on. We did have a number of crossovers, meaning that allocation to one group did not necessarily mean that they underwent that intervention, with about 10 patients total crossing over from one way or the other. And then finally, we did use the composite outcome of complications. We've used that before for population level studies, but it's not necessarily validated, and there's no real commonly accepted outcome for this type of trial, so that would be one of the limitations. In terms of further discussion, shortly after our study was published, another much larger trial called the PERFECT trial was published, which was a Nordic trial and included, I think, approximately 2,000 patients. Similar question about whether delaying surgery was safe. Some notable differences, though. The inclusion criteria for this trial included those without imaging, and the primary outcome was very different in that the primary outcome of the PERFECT trial was perforation at the time of surgery, not necessarily complications after the fact. Time to surgery was a bit different. Our immediate surgery patients underwent surgery quicker than those in this trial, and our delayed surgery patients were a bit faster than those in this trial as well. The PERFECT trial also had reported lower risks of complications at 30 days than our trial did. We did have a different definition of complications. Regardless, though, their findings were very similar to ours in that appendectomy, if done within 24 hours, did not increase the risk of perforation compared to those that underwent an earlier appendectomy. So our conclusions really is that delaying appendectomy is non-inferior to immediate surgery. And I think surgeons can consider this approach in similarly resource settings, especially if surgery can be performed within 24 hours. So I'll stop sharing and thank you for inviting me to give this review.
Excellent talks. Thank you very much. So we have a few questions and comments coming in. The first is to yourself, Dr. Patel. Did you exclude children from your study?
Yeah, we excluded those under age 18. There's two reasons for that. One is that we have a different group of surgeons that manage that. Those are the pediatric surgeons. And so they don't necessarily have the same type of access to dedicated OR as we do. And then the other issue is just getting it through ethics. So it was a bit more challenging when children are involved. So it was more of a pragmatic decision as well.
Of course, of course.
Sunil, can I ask a quick question? Yeah, thanks for this great presentation. I completely agree. What are your explanations for the low morbidity? It's because the surgeon is more fresh, or it's the use of antibiotics for 6-8 hours before surgery, or you didn't give antibiotics? I don't know. What are the interpretations?
Yeah, very common question when I present this work. Why is it seemingly safer to delay your surgery to the next day when it's a process of inflammation, potentially leading to complications and infections and whatnot? The number one complication we saw was return to the emergency department for any number of reasons. One of our co-authors proposed that maybe, you're operating in the middle of the night, your explanation to the patient when they're being discharged is through the veil of like being very tired and your communication style is not very good at that point. But we don't have a great explanation on why someone would have increased complications undergoing immediate surgery. So something that's been asked about before.
And so antibiotics for the delay, or no antibiotics?
Yeah, so both groups got antibiotics in the emergency department and then were redosed in the operating room as well.
Oh, okay.
Can I ask about length of stay in the delayed group? Did they end up having a prolonged length of stay overall and therefore increased cost associated with that?
Yeah, another great question. So this is one of the first trials I designed, and you look back and you say, how can you possibly have designed a trial without a very important outcome being captured, which was length of stay? So we actually didn't build that into our protocol of capturing that. I can see that the standard of practice here is patients go home the next morning if they have surgery in the middle of the night, or immediately after surgery once they meet our discharge criteria from recovery room. So when we looked at it as a secondary analysis at one of the institutions, the overall length of stay, there's about a 6-hour difference in length of stay, and it primarily related to being discharged at 8 a.m. versus 12 o'clock or 1 o'clock in the afternoon after they've met their criteria.
There's a question that's come through for both of you, if that's okay, and it's just about routine practice. Do you routinely consent all patients for ileocolic resection or right hemi who are undergoing appendectomy? What's your view on
that?
Jeremy?
Yeah, if it is an uncomplicated appendectomy confirmed by CT scan and the St. Antoine score, for instance, the probability to need to do at least a conversion or a right hemi or an ileocecal resection is almost nil. Among the 2,000 patients that we published in surgery 2 years ago or 1 year ago, there were no cases like that. Again, if you exclude plastron, abscesses, and all complicated appendectomy, it remains 80-85% of the patient. You can delay surgery. You can do surgery in ambulatory room with no problem at all. I don't know what is Sunil's opinion, but it's something which is occur almost never.
Yeah, agree. That for us would be exceptional. I'm not sure necessarily that my colleagues would differ in that statement either. So that'd be the exception when diagnosis is unknown. Maybe you think there's some reason there's Crohn's disease or something, but generally we just consent them for the appendectomy.
And it's a good argument to delay surgery, to do it in the morning on the daylight, until do it to be at 3 a.m. in the OR to do a right TEMI. So it's another argument to delay surgery.
And I noticed in both your studies, the majority of patients had preoperative imaging, either in the form of ultrasound scan or CT scan. How does that work with radiology locally? Because I know certainly we will not get ultrasound scan in our hospital after 5 o'clock, and we often have to beg and plead our case for a CT out of hours. Is that the case where you work, or are things different?
Yeah, so probably another difference in Canada versus the UK. I don't know about Europe, but I've heard that before. We have no problems. Often we don't get a consult unless, like, the emergency doctors won't consult us until there's imaging results. So there's a chicken and egg argument there. Like, did we force them to get imaging, wouldn't accept the consult without imaging, or do they feel that like provides better justification? So nowadays it's very unlikely any appendectomy patient doesn't have imaging. And in fact, we looked at across the province, again, about 50,000 patients, and year over year, there's less and less patients going to the OR without any imaging. So in Ontario, probably in 2020 or 2019, it'd be like less than 5% of patients wouldn't have imaging, regardless of the time of the day.
Yeah, same in France. Radiologists on call do CT scan for any suspicion of appendicitis with no problem.
I think in the UK, or certainly north of the border in Scotland, we'd get a lot of pushback from our radiologists. We seem to have settled on scanning patients with right iliac fossa pain over the age of 40. So getting a CT scan for them because of that association or the increased risk of colorectal cancer. But I think that's more common in men than it is in women. Alison, I don't know whether that's the practice in your hospital as well.
Yeah, pretty much, yeah.
And I think there's scope for somebody to be bold and to try and replicate or build an NHS modified pathway for ambulatory appendicectomy, because I'm not aware of one in the UK. And also looking at, although I accept that I think we have veered towards, there's very few appendicectomies happening overnight these days. Not like when I was a registrar, I was frequently up till 4 and 5 in the morning. That's where I did most of my operating. But how successful do you think your models of care would be and the outcomes would be in a setting that we have just described?
Well, I think delaying appendectomy up to 24 hours, I think, is really right. Like, that's reproducible. That's been, I think, shown in a number of different settings. In fact, you could probably make the justification that you guys can push less hard for imaging at 8, 10, 12 o'clock at night, because you don't want to know the answer until the morning anyway. So I think delaying appendectomy, regardless of whether it's a clinical diagnosis or because of resources can't get the imaging, is probably quite safe. And I think that most surgeons, trainees, registrars can identify when patients in an unwell situation that, like, clearly this is going to be veer off the track. But I think, as Jeremie had alluded to, 85 to 90% of patients are probably uncomplicated appendicitis, probably can wait quite safely and are not particularly unwell.
Yeah, I agree. Especially when you said to them, go home, have a great night in your bed with just antibiotics, and come back at 8 a.m. and I will operate you. You will be discharged 4 after. It's easy. And what I didn't say, because we didn't evaluate it with the score, but the acceptance by the patient of ambulatory surgery is excellent. It's everywhere, ambulatory surgery, in all the newspapers. So when you say to the patient, it's a small appendicitis, come tomorrow, you will be operated and go back home again. So you won't sleep at all in the hospital, eat the bad food of the hospital. They are all very, very pretty happy.
Can I just make a comment? Sorry to interrupt, but you know, in our setting, we're really struggling with inpatient beds. So when you look at the newspapers here, there's a lot of talks about extended emergency department stays for admitted patients. The medicine patients really struggle with this. They could be in the emergency department for 24, 48, 72 hours as like a boarded inpatient, but in the physical emergency department. And when Jeremie describes someone having to go home and not have to be in the chaotic emergency department while waiting for appendectomy, I think probably our patients would find that attractive. At least those that with low anxiety would find that attractive, because it can be a pretty rough stay in the emergency department throughout the night.
Can I ask two questions? I noticed the patients were sent home with antibiotics. Did they continue post-operatively? Were they sent home to complete a course, or were they stopped once the appendix was out?
No, once they're discharged, and if we have the confirmation that it was not a complicated appendicitis, we are discharged with just painkillers and no more antibiotics.
Great, great. And can I also just ask, have you done any cost-effective analysis on this pathway?
No, but it is obvious that you earn money, because the hospital earns the same amount of money for an appendectomy with a patient staying 1 day in the hospital or 0 day in the hospital. So you automatically earn more money, because the bed that you would use for the appendectomy can be used for leftemy, rightemy, whatever. So by construction, it's with the French system, which pay by the act, you earn bed, so you earn more money. It depends what you put on the bed.
Yes. Thank you.
Can I ask, both of you alluded to, or certainly Sunil excluded children from his study. Jeremie, did you do the same? And the second part of the question is, do you think there will be a natural progression and evolution towards both of your pathways for the management of children with appendicitis?
I can see why appendectomy in children cannot be done in ambulatory surgery. They do already a lot of ambulatory surgery for very complex procedure. Children heal most of the time better than adults. So it's just a fear, but for probably nothing. Let's start by operating adults with appendicitis in ambulatory setting. Increase our 26%, increase your 0%, and clearly, maybe in 5-10 years, children will be also operated in ambulatory pathway.
I have to say, for delaying appendectomy, at least in the Canadian setting, I think the pediatric surgeons were probably first on doing that. At least our local pediatric surgeons would rarely, if ever, offer a pediatric patient an appendectomy at night. So at least in our setting, I think they were more of an early adopters of this approach.
Do you mind me asking, what are your views on the conservative management of acute appendicitis? It was getting a lot of attention. I know myself and Michael have been discussing this recently. It got a lot of attention during COVID, and there are places where it's almost become the default management option. What are your views on that?
So interesting. So that wasn't part of our protocol. So if someone got enrolled in this study, they were going through for appendectomy. I have my personal opinions on conservative management. I personally don't believe it's a great option considering the failure rates and the simplicity of the operation, but I recognize kind of resource limitations. One thing we've noticed with kind of this adoption of the technique. A patient's seen at 8 p.m. the night before. There's no time to do this case before midnight. They get put on antibiotics and they're better the next day. Now we're trying to decide, should we follow through with the appendectomy that's booked at 8 a.m. or should we just let them kind of convalesce with the antibiotics at home? So although this is not kind of the intent of this study, I think it actually brings that question to the forefront, because all of a sudden you have 12 hours of observation and someone's gotten better. Do you really need to go ahead with the appendectomy? So I don't know. I still think appendectomy is the standard of care. It makes me concerned when you see the failure rates, which I think are up to 50% in some studies. But I feel less strongly about that after seeing someone get better overnight. And if they really don't want surgery, well, that's fine. That's ultimately their decision.
No, it's a very good question. And when we operated the patient after sending them back home with antibiotics, and we operated at 10 a.m., sometimes the appendicitis is almost gone. But when you compare 2 or 3 days of antibiotics, sometimes in the hospital, to a 3 small trocar appendectomy in ambulatory setting with no hospitalization at all. And again, 50% will be operated within the next 2 or 3 years. Not talking about the small cancer that you can find and so on and so on and so on. No, it was a good idea to give antibiotics instead of surgery. But when you compare to 30 minutes laparoscopic appendectomy in ambulatory pathway, it's going to be difficult to give antibiotics for 5 days and so on. So I think it's still a good option when you cannot operate a patient. It's a good option when you have a plastron. Clearly, you need to delay, but not 6 hours, but maybe 4 to 6 weeks. But so far in France, it's not trendy to give just antibiotics to patients.
Thank you. Another question's just come through for Dr. Patel. Did you notice any difference between whether it was consultants or trainees performing the surgery, particularly those done through the night?
Yeah, so the situation in our practice setting, at least, is trainees don't operate at night without the consultant there. They may not be scrubbed in, but they have the same type of oversight that they would during the day. So we couldn't tease that out, like who was the primary operator, the trainee versus the consultant. I would suggest that in our settings, most of these cases are pretty much handled by the trainee with just oversight from the consultant as either the assistant or in the room or in the OR lounge, but available. So our practice pattern doesn't change night or day.
Thank you. I think that is all the questions from the audience. I would just like to thank you once again for 2 fantastic presentations and an excellent discussion afterwards. Really enjoyed that. And I'd like to thank all of our members for tuning in as well. A really good turnout, unsurprisingly. Thank you very much for your time.
Thank you very much. Bye-bye.
Bye.
Thank you.